Let me please introduce my presentation. I will talk about the loco-regional treatment in treating HCC. Of course, I am very happy to chair this meeting with Eastern and Western School of Intervention because this is a large dilemma in intervention, as an HCC is the third most common cause of cancer-related deaths worldwide, and the systemic treatment remain very limited. The surgical resection is very few number of patients are valid for it. The HCC is a preventable disease. If we can detect, if we can cut this cause, hepatitis and ethanol and NASH, so we can avoid a lot of causes leading to HCC. And in our country, in Egypt, we face a lot of problem regarding the HCC, as in North Africa is considered the third most common place all over the world affected by HCC and cancer-related deaths. And this is in spite of our population is not so large number of population, but we face a lot of problem. So I think in this multidisciplinary meeting, we should know the natural history of HCC and which point we can cut the circulation of developing advanced HCC and when we can treat it. There is a dilemma regarding what is level of evidence and what is the recommended strong treatment. At the end, we find that the sorafenib or the oral anti-proliferative angioproliferative treatment is widely recommended and used with very high evidence, level of high evidence and a very high level of recommendation, but on the ground, it's a very poor treating option, and we have a lot of problem regarding this. And so the level of evidence and strong recommendation regarding the choices of HCC, we now it's a dynamic process, and all the world groups now revise the choices for treating HCC. The tumor burden, liver function, performance status are very, very important pillars to take a decision for the patient. We face a lot of problem regarding the HCC, regarding the different staging system, the size limitation, the number limitation, and the vascular invasion. There is many staging system to how to treat the HCC, TNM, Okuda, Japanese, Chinese, Italian, but still Barcelona Clinic staging system is the best prognostic classification to treat the patient. But this classification system, which is the most famous classification system, we have only the option for treating HCC. Less than 30% of the patient will can have a curative treatment, and they put the 3 centimeter cutoff size to use ablative procedure, and after this they put most of the patient in palliative treatment with TACE or different types of embolization and systemic treatment. But in the last published version of the Barcelona HCC, they gave us more options regarding the tumor, and they maybe reach up to 4 centimeters to treat the patient with HCC. So first issue, in spite of the Barcelona is the most famous classification system, it's provide very low number of or low percentage of patients with curative treatment like surgical resection or liver transplantation and ablation, because embolization and systemic treatment considered as a palliative treatment. So the Eastern people, especially in Hong Kong, starting to make a new staging system, and they released the staging system at 2008. It's they starting to develop Hong Kong classification system, and Hong Kong classification system released at 2015 with a new edge. They consider the vascular invasion is a very important issue, and they increase the size of the tumor up to 5 centimeters. At this point, we can do resection and ablation as a curative treatment. So this is very important if we're talking about the ablative procedure, because the HIFO is ablation. So there is another classification, valid classification system talking about the ablation till 5 centimeters. And of course, the most important thing is the prognostic value of the tumor. In comparison study, the Hong Kong group, they found the Hong Kong classification system with very good results and better prognostic value. So when we go aggressive very early, it's more better for the patient. And of course, we should consider very well the Asian experience in treating HCC, because the Japanese people are the first one to do right lobectomy, and they are the first one to invent the transarterial embolization, and they are the first people using the super selective TACE. So, and even the Okuda system is the first system to merge the clinical of the performance state of the patient and the parameters of laboratory finding of the patient. So the Japanese experience is very important, and in the Japanese association or a Japanese Society of Hepatology, they make 4 centimeter is another edge for ablation. So you can, after reaching 4 centimeter, you can make an ablation, even if the tumor is more than 4, but with no vascular invasion, you can do ablation. And you can see this chart showing us what about HCC progression in Japan. In Japan, the progression dropping of the number of the patient of HCC. And regarding the Japanese people, they treat most of the people at the curative stage with 60% of the patient with curative treatment. And this is very important. So the Japanese experience is very important to look at it. And of course, the Hong Kong classification and Chinese association as well. So this study showing us the last 3 decades of experience to treating HCC in Japan. In Japan, they treating about 80% of cases detected by screening. This is very important, how to prevent the progression of HCC. In Japan, they reach about 60% patient with Milan criteria, so the curative treatment maybe reach up to 70%, either surgical or ablation. In Japan, they make an follow-up for survival up to 15 years, and this is great for HCC. Also, they found a very good comparable result between radiofrequency ablation and surgical resection. And this is great. After 10 years, the surgical resection and radiofrequency ablation, the survival reaching up 24%. Also, the Chinese classification is very important. They reach up to 5 centimeters for the tumor valid for ablation. This is very important. If there is no major vascular invasion and the tumor size up to 5 centimeters, you can use an ablation. This is very important. But many hospitals and universities like San Diego, California, they make a merge between Hong Kong and Barcelona and put their guidelines. And I want to give you rapid ideas about the available loco-regional treatment. Of course, there is ablation like radiofrequency, microwave, cryoablation, and a reversal electroporation. And this is not an ablation, but it's considered as needle guidance. So they put it as needle guidance. Of course, the radiofrequency is the most famous and the most cheap one. And a lot of people has an experience regarding the radiofrequency. And the other issue is embolization. We have different type of embolization: transarterial embolization, transarterial chemoembolization, transarterial diptase, what we call diptase, and of course radioembolization. In some Asian countries, there is also blunt embolization. The embolization is forming a mixture from lipidol, chemo agent, and make a mixing of both and adding a sponge or gelatin gel foam to increase the embolic effect. Usually, we prefer super selective or segmental embolization. But this is very important to make a proper patient selection, proper patient preparation, and the timing for making the chemoembolization. The diptase is more less toxic and more specific. We make a loading of the chemotherapy on the particles and then inject these particles inside the tumor. The radioembolization, we're using the yttrium-90 by the same technique like chemoembolization with some precautions. We inject the tumor, but this is without embolization. This is just introducing the radiation particles to the tumor. And sometimes we used what we called radiation segmentectomy in some cases. Usually, the radioembolization is preferable technique for transplantation bridging. The thermal ablations radiofrequency is the most widely used technique. It's not only related to the power, and some people talking about the microwave as more powerful than the radiofrequency, but it's not only the power. In radiofrequency, we have different types of needle, so we can choose according to the shape of the tumor, which type of the needle we can use. And the ablative procedure now can doing difficult location and using what we called non-touch technique. A difficult location, like Professor Simon did in Haifu, we did a different technique to avoid injury of the bowel and to avoid injury of the vessels. And according to the direction of the power, we use a different needle and maybe perpendicular on the bowel or parallel to the bowel. And also there is a different technique, what we call the non-touch technique. In this technique, non-touch technique, we use two needles and put the tumor between it and doing an ablation for this zone. Also, we have new hopes. The first hope is the radiotherapy. And now the radiotherapy, as professors in Hong Kong or Shanghai or even in Egypt, and I think in most of the European centers, they now using the external beam radiation but it's still low level of evidence and still weak confidence and weak recommendation. But now we can, in combination with CT or MRI machine, they can do very precise result, especially in portal vein thrombosis. And this is the American Association of Radiation Therapy. They suggest the radiotherapy to be used in some unresectable cases, either alone or in combination with other methods of treatment like TACE or radiofrequency. And I put this slide for a very important issue. We must, as a society, and we must, as a doctors treating and using HIFU, to put the HIFU in as an alternative technique in some cases, not all the cases of HCC and not all the cases of metastasis, to put the suggestion of rule of HIFU to treat the HCC. And this is what I try to do. And of course, all of you doing this. And like this very innovative paper at 2010 by Professor Orsi and Professor Zhang, and they put the HIFU to treat difficult location HCC, like this tumor. It's insinuated between the branches of hepatic veins and IVC. You can precisely see the tumor and treat it. Like this tumor at the hilum of the liver, insinuated between the IVC and the portal vein. No any other methods of ablation can do this technique. Like this case, for one of my cases, this patient complaining from very small hilar tumor at the liver hilum. We can't do ablation by any methods, and his lab is not good. He is not suitable for TACE, and we treating him for by HIFU and in single session, and we follow up them up to 2 years. And you can see this is post ablation. 1 month is completely ablated tumor. Even at 6 months and 12 months, we hardly appreciate the tumor. We can't even see where is the site of the ablative zone. Also, we can put the HIFU in these cases after TACE, like Professor Simon showed us, after TACE with borderline size tumor, we can use HIFU as alternative treatment after TACE. You can see this is case of large tumor treated with systemic therapy with residual tumor. We do TACE, and this is the residual tumor. It's marginal tumor and with large crescent area at this point. And this is the PET scan showing us this is residual tumor at the hepatic dome. We make an HIFU for maybe 2 hours, 2-hour session, maybe 2,000 sonication, and this is the results. We almost ablate all of the residual surrounding the tumor, and we follow up the patient after 9 months. There is no residual. Also, this is very important indication for HIFU. Some patients are out of Milan criteria. Maybe the alpha fetoprotein more than 1,000. There is and they need to make a transplantation, and they have ascites. And we have this small lesion. We make a pre-transplantation HIFU for many patients in our center, even with ascites. And you can see this is an ablation after HIFU, and this patient go for transplantation. Another indication not related to HCC, like metastatic liver lesions and cholangiocarcinoma. The cholangiocarcinoma is very, very good indication for HIFU because it's hypovascular and we can treat the patient very well by cholangiocarcinoma, especially if peripheral type. But I'll show you one of the more difficult cases. It's a central type. This is 25 years old man with pathologically proven cholangiocarcinoma. We can see this is the central type. We put a stent, metallic stent, and treating the patient, and you can see this is very good response. And even the track of biopsy is ablated. And this is MRI and CT after. Of course, we can put the HIFU also in a small HCC lesion in normal location as a start to compare it with the radio frequency. Like this study by Professor Tantu, and of course we missed him today, and he have a very good result as comparing the HIFU with radio frequency. Regarding the metastatic lesion, it's another issue. We must introduce the HIFU like Professor Vidal talking about the immunomodulation and immune response, because the HIFU is not only mechanical destruction of the lesion, but it's improve the drug delivery and improve the immunotherapy of the patient and change and alternating the nature. And you can see, of course, all of you have a very good result about this small metastatic lesions, very good, very easy, very accessible, and you can see a good response easily after the tumor. And this is very easy case. You can see what we called even like a hemorrhagic coagulopathy, and this is the very good sign of very good ablation. This is indicating the HIFU is strong, it's not weak. And this is very good result of very simple case. Also, I show you this case with metastatic lesion insinuated between the bowel and the liver surface. And after HIFU, very simple case, you can see this is like a wedge-shaped ablation. This is also a very good indication that the HIFU is strong, and sometimes you can't see the infiltration of the tumor, but the HIFU is spread throughout the infiltrated area. And this is good also. Sometimes we do a HIFU, and if the lesion is responding to the ablation, that means it's not a normal hepatic tissue. This is also another indication for this very simple case, but it's just below, behind the portal vein, and we can't reach it. The HIFU give us a very good result. So in metastatic lesion, it's not only an ablative procedure, but also it's a modality of treatment enhancing the immunomodulation, improving the quality of life. And I think the HIFU should be giving us better results if the distance is lower, the size is smaller, the vascularity is less, so we can get a better result, and we should put the HIFU in this area to treat the patient. Thank you very much.